Okay, it's 11:01, so I think we'll start just because we have a packed agenda. Good morning, and welcome to our diagnostics program area of the MGB Center for COVID Innovation. Just like to welcome everybody. My name is David Walt. I'm co-director of the MGB Center for COVID Innovation and am professor of pathology at the Brigham. And I'm also a core faculty member at the Wyss Institute at Harvard University. My co-director is Gary Tierney. Gary, would you like to introduce yourself?
Yeah, hi everybody. Welcome to the Diagnostics Town Hall. I am a pathologist at Mass General and a member of the Wellman Center for Photomedicine, and I'm an engineer and a pathologist.
Great, and we'll be hearing from Gary in a few minutes. Last week we launched the center, and we simultaneously both held our first town hall on devices, which Gary will report on next. This town hall, as I mentioned earlier, is focused on the diagnostics program area. So the agenda today, first of all, Gary is going to introduce the center and report on the first week's progress in the devices program area. And then that's going to be followed by 4 speakers who will set up the diagnostics program area from the clinical perspective and from the clinical laboratory perspective. And then I'm going to describe the diagnostics program area and discuss our planned working groups and next steps. And finally, we'll answer any questions and close the session. So I'm going to turn it over to Gary now, who will discuss the center structure.
Hi, everybody. Next slide. So let's start first with the mission statement of the MGB Center for COVID Innovation. And the mission is to facilitate the development of new innovations to flatten the COVID-19 curve and protect the frontline clinical staff across the MGB community and beyond. Next slide. So why are we here? This all started about 10 days ago when there was a tremendous amount of outpouring from the community to provide innovations, especially at that time focused on developing new PPE devices to help clinicians on the front lines and patients with COVID. Essentially we recognized, and the hospital leadership recognized, a strong need for these following things. One is educate the larger community on what is needed and what we need to know for new innovations to be safely deployed and used. The other is to help identify internal and external resources necessary to operationalize these ideas. And then finally, to identify and empower experts from inside and outside the MGB community that can move meritorious ideas towards practice. Next slide. So the MGB Center for COVID Innovation has 4 pillars. The first, which has already started and well on its way, involves devices, and I'm going to talk about that next. Next slide. Today's particular town hall is focusing on diagnostics, which we're launching this week, and will follow a similar structure and pattern as the devices pillar. And then we also have plans to do data analytics as another major program area, and finally, early stage therapeutics or therapeutics research. Next slide. So the general plan for each one of these program areas is to kick it off with a series of virtual town halls. And then after that, people sign up for working groups, and the working groups form that cover different specific topical areas within that particular program area. The working groups are tasked with deciding on best paths and coming up with a means for efficient implementation that can help partners healthcare, and if that is completed, to work on helping hospitals nationally and statewide. Next slide. So I'm going to describe a little bit about what we have been doing over the past 10 days for the devices program area and the devices pillar of the center. What we needed to do, there was many different ideas, many different groups working on a variety of different options for devices to address COVID, such as personal protective equipment or PPE. And what we felt that we needed was to pare down these different options and provide infrastructure and support that could deliver hundreds of thousands of viable new PPE devices as the crisis is surging in the upcoming weeks. So previous slide, please. So what we did down below, we have sort of a timeline of how things have progressed, and they progressed very rapidly. Friday, March 20th, the center was established. And then on Tuesday, March 24th, we had the first town hall on devices, and we called the community to action. And in that town hall, we had more than 500 participants in the virtual town hall. The next day, we established the working groups. We identified working group leaders and core support functions for the devices portion of the center. The following day, Thursday on March 26th, we kicked off the working group meetings. The first working group meetings, we had more than 100 participants in each working group. There's about 150 to 200 now in all of the working groups. And then the working groups met and formed subgroups within the working groups where they started presenting designs. And as I had said before, pare down these designs to come up with the best few possible options that could be mass produced and implemented and disseminated to the hospitals within the 1 to 2 week time frame. At this point, the center, predominantly devices, has over 60 full-time employees and 800 members with 7 active working groups. Next slide. Next slide. All right, so here are the different working groups. As I said, there's 7. Many of them are actually focused around specific personal protective equipment. The first one is face shields, and the team has worked really hard and has come up with 2 potentially viable designs that can be mass produced and disseminated. And those are currently undergoing clinical testing. The surgical masks team has multiple viable options, and they're getting prototypes and starting the testing process soon. The reuse working group involves sterilizing or disinfecting existing or used PPE, and has made a tremendous amount of progress with determining really viable methods for sterilizing N95s, which is the one type of PPE that's a particular concern for shortages. And that's being undergoing implementation at Mass General Hospital, and that hopefully Brigham and Women's and other partners hospitals will soon follow. We also have a working group making new N95 masks or respirators, and 2 new 3D printed designs have come to the top there, and the group is currently working on developing testing and validation protocols. We have a working group that's dealing with ventilators, and they've found 2 prototype ventilators that could be produced at high scale and disseminated within the time frame of the COVID surge. And they're actively working to either fabricate or get those prototypes so that they can be brought through the testing and validation process. And we have a full body protection working group where there's a screening phone booth has been identified where the patient or the caregiver can enter an enclosed sort of plexiglass booth and do things such as give screening tests and be much more protected than without being enclosed in the booth. And there's also a patient isolation hood, which can be used for procedures that are likely to aerosolize a lot of the COVID virus. And that's being investigated right now with a prototype hopefully coming online for testing and validation this week. And finally, we have a validation subgroup, and this validation subgroup essentially serves a core function to all of the other device-specific working groups, where they're providing key expertise that is required both in the testing process and in the validation process, so that we can move quickly forward to production on a validated design. And I would be remiss if I didn't say that there's many, many other people involved in this process, including Incident Command at Massachusetts General Hospital, and also now at Brigham and Women's Hospital. In addition, many, many people across the system have been helping and supporting the working groups. And with all of this help and support, we believe that all of these groups will have products ready for mass production and deployment in the upcoming weeks. Next slide. This is just a photograph of some of the prototypes that have either come from or passed through the working groups. You can see a face shield. On the upper right-hand corner is a 3D printed N95 respirator, and a variety of surgical masks on the bottom. And it's just an example. We've actually vetted and looked at many of these fabricated new PPE devices, and the working groups are working hard to vet these different designs, pare them down to the most likely options to have an impact in the next 1 to 2 weeks, and then move on towards validation and manufacturing. So that's it. That's the update of what's been going on in the devices pillar of the MGB Center for COVID Innovation. And we are very excited to add the diagnostics pillar starting off with this town hall today, and look forward to working with all of you on the important topic of diagnostics and how it can be brought to bear on the COVID-19 crisis. David?
Great. Thank you, Gary. So the next section of the town hall, we're going to hear from clinicians who are really in the trenches dealing with this every day. And we've asked them to set the stage for us with respect to the diagnostic needs. So the first clinical perspective comes from folks that are really on the floors dealing directly with patients. And we'll first hear from Mike Klampus from the Brigham. Mike?
Hi, yes. So good morning, everybody, and thank you for the opportunity to share some thoughts with you. So speaking towards diagnostic needs in particular, my thoughts are as follows. So in no particular order, first of all, I think we need to get more sensitive testing. Our limitation right now is that our primary test is a nasopharyngeal swab, which is sent for PCR. And while it's an easy to obtain test, its limitation is that particularly early in the course of disease, it has limited sensitivity. Sensitivity is probably only around 70%. What that means for us in practice is that if a person has a high pretest probability of disease, we have to get at least 2 tests if in the instance where the first test is negative, and sometimes even beyond that if the suspicion remains very high. Conversely, when we want to rule out disease and say a person does not have disease, that also requires, in most instances, at least 2 tests. So it's both an inefficiency and leaves room for error that might lead us to either miss a patient and therefore fail to take the appropriate precautions for that patient, potentially discharge a patient who has positive disease to a care facility, which in turn puts that facility at risk for a cluster of disease. So that's an important limitation. Next item I would say is to continue working on the turnaround time of testing. Now, we have seen substantial improvements in that from the early days of this outbreak. When we first were sending our specimens all to the state laboratory for testing, turnaround time was on the order of 4 to 5 days at cases. As we've brought testing in-house, that has improved substantially, and now we're up to turnaround times that range between 6 to 24 hours. There is actually a platform now that's available to some hospitals on a limited basis to our hospital, which has a turnaround time of 45 minutes. So lots of improvement in that space, but I think that as far as I'm aware, there's only one platform right now that has that very fast 45-minute turnaround time. So more in that direction would be helpful. Another avenue to pursue is home testing. As we know, one of the particularities of this outbreak or this disease is that in many instances the disease is actually mild, and that therefore there's no need for that patient to be hospitalized. There is still, however, value in being able to test that patient, and the value is that first of all, if the patient has a high-risk profile, meaning older, underlying chronic disease, immunosuppressed, etc., there's value to knowing that result, because should the patient be hospitalized, it's good for us to know up front. Number two, we anticipate that we'll have evidence guiding therapeutic options shortly, and if a medication will prevent a patient who's vulnerable from being hospitalized, that would be a good reason to know, even if they are still in the outpatient setting. And number three is that by keeping the patient at home for testing, it enables us to further reinforce the importance of physical distancing and social isolation, and prevents a burn on PPE, which would be the case if the patient came to our hospital, one of our testing facilities, to get tested. So home testing would be an option. Part and parcel with that is considering alternative specimen collection devices and methods. So again, our primary methodology right now is a nasopharyngeal swab. Limitation over there is that, first of all, there is a shortage of swabs, so we're looking at swab alternatives. But also, I think, thinking more broadly, are there other ways we could test besides putting a stick in the nose? Are there different kinds of sticks that are more comfortable, or that are easier to manufacture and to acquire? And are there other ways we might consider testing besides just a nasopharyngeal swab? For example, a breathalyzer test, for example, looking for volatile organic compounds, or a urine-based test. There are examples in other infectious diseases where we have things like this. So would that both potentially improve convenience, less invasive, and perhaps improve the limited sensitivity of our current methodology? Here's a real pressing need for us, and that is the science trying to differentiate between RNA persistence versus active virus. So the issue over here is that we know that even after a patient is clinically recovered from their syndrome, if you continue to do nasopharyngeal swab testing, you will often continue to get positive results. We know the quantification of virus does go down, but what we don't know is that in an instance where you have persistently positive NP swab RNA tests, does that mean the patient is still contagious or not? And this has big implications really for our workforce, who right now we're taking conservative track and saying we're not going to let you come back to work until those NP swab PCRs are truly negative. And that can sometimes be on the order of weeks to reach that point, even though the patient is clinically recovered. And our big fear is that all we're doing is recovering residual RNA that does not correspond to active virus, that does not correspond to ongoing transmission risk, and that therefore we are unnecessarily keeping vital people out of the workforce. So a study correlating in the convalescent phase of disease, the recovery of virus, the quantification of virus, and then viral culture to see if that's actually viable virus or not, I think would be helpful to inform that. The related issue over here is digging further into the time course and meaning of serological antibodies, markers of immunity. At what time period does IgM appear versus IgG? And more critically, what's our assurance that the presence of antibody suggesting immunity correlates with true protection from disease? Can we determine that individual can truly sustain additional exposure to the virus and not get sick? As a general point around testing, I'd say that to the extent that one can use existing platforms, if you're using with conventional testing methods, and minimize the need for novel reagents and kits, that will facilitate the feasibility of additional rollout. Okay, I'll pause over here and pass the baton to my learned colleague, Dr. Walensky.
Thank you so much. Thank you, Gary and David, for the opportunity to be here. I have the dubious task of going after somebody who I deeply respect. So I will echo actually quite a few things that Michael Klumpus has just talked about, and they really mirror exactly the points that I was going to make. I want to just make sure everybody understands that in order to do the test right now, not only do you need somebody to come in-house, you need to have the nasopharyngeal swabs, you need to put on the PPE. The CDC is still recommending N95s for everybody conducting the test. That patient then goes back home or gets admitted, and then there needs to be a phone call for follow-up. So it requires actually workforce both at the front end and at the back end. It requires our highest level of PPE, which are N95s. And then, as Michael said, there was turnaround time at the onset of 5 to 7 days, which was really not viable. So all of that really makes things like how do you know how to cohort patients? How do you know whether patients are safe for procedures? How do you know what PPE to use? And are we overusing our PPE, which is such in limited supply? So real challenges on all ends. So I think the turnaround time is a key one. I also want to convey that we're still not at a place where the volume of testing is where we really want it to be. We've loosened some of the constraints on the volume of testing, and now we have a longer list of the kinds of people we are testing. Certainly we're testing people with symptoms who come into the emergency room, but for example, we're not testing all patients who are on the OB wards, and there's been discussion about wanting to do that. We're not testing all patients who go to the OR for any reason. There's certainly been discussion about wanting to do that. So we are still at a place where the volume of tests that we would want to do, we're way better than we were 3 weeks ago. But we're not at a place where the volume of tests even now is where we would really like to be. Swabs, as Michael said, are also at a shortage. I also want to convey the real challenge with sensitivity, and I know that's a challenge we and Michael have been dealing with on a day-to-day basis. Right now, every negative test in this hospital has a chart review associated with it. We are reviewing every chart of a negative test to ensure that that those people really have a low pretest probability or really don't have something that we can attribute their admission to for another reason, and we really don't believe that this is related to COVID. For those who we don't believe that's true, we send a negative test, and I know at our institution and at the Brigham, we have each had situations where people have had a negative test followed by a positive test. That's deeply concerning as we think about infection control. It's also deeply concerning as we think about containment in another phase. If we were to be revisiting this disease in the fall where we really had more tests, what does the message of a negative test mean when the test is really only 70% sensitive? And how do we convey that to the public in a way that sort of says, we think you're safe, you might be safe, but maybe not. So I think the test sensitivity is really key. I want to relay that a point that Michael made with regard to discharge planning. It's been very hard to get people to mobilize to other other places, such as dialysis centers, such as subacute nursing facilities, who really want to be sure that the patient does not have disease when they come because of the implications if they do, or to cohort them appropriately. And that is all relying on our poorly sensitive test. And in settings where people have had disease, as Michael conveyed, a poorly specific test where people may no longer be able to transmit, but their test remains positive because the virus is no longer viable. When we think about what this might look like in wide-scale testing, sure, it would be lovely to not have to use these swabs. It would be lovely to have a rapid turnaround. It would be lovely to have point-of-care lateral test strips and the whatnot. It certainly would be wonderful if we didn't have to deploy healthcare workers to both collect the information as well as reply and give people information. We spent an extraordinary amount of time teaching people what their test results mean and the implications of those test results results. So really something that is easy to do, easy to interpret, and quite sensitive would really be, a dream come the fall, I think. Finally, I want to convey some of the issues that Michael was talking about with regard to serology. I think we know from data from China that up to 60 to 85% of people had disease and were never tested. I think some models have at least conveyed that. What does a serologic test look like? How do we use that information, as Michael was saying, to deploy our personnel, our healthcare workers? Would it be safe to take somebody whose serology was positive, who never truly had symptoms, and put them on the front lines of taking care of a bone marrow transplant patient, for example? Would that be something that we might be able to do one day if we were confident that positive serology meant that they would be safe in taking care of those patients? And we certainly have quite a few immunocompromised patients where it would really be nice to match them with healthcare workers who are not at risk of disease. And then, of course, this, as we think about and seeing in the news a pool for convalescent titers and how convalescent plasma might be used as a therapeutic approach, I think there's been a lot of interest in understanding who has had disease and whether those convalescent titers are high enough to actually give some of that plasma to people who are sick. Where does it where in the spectrum of disease would that convalescent plasma be best deployed in order to improve outcomes? So with that, I will close, but I think it's extraordinary to think about how much better it's gotten in the last 3 weeks. It's also extraordinary to think about how much better we have to go.
Thank you very much, Drs. Klompus and Walensky. Really great setup for that. And now we're going to go to a different kind of trenches in the clinical lab, and both Neil Lindeman and John Iafredi both are really at the front lines in terms of dealing with samples coming in and the need to turn around. So Neil, I'll turn it to you.
Thank you, David. Thank you for inviting me to participate. So I'm going to just tell a little bit of a story of testing at the Brigham and Women's Hospital, and I'm going to focus on all the things along the way that could have perhaps been better. I don't want you to think we're not capable, just like I'm trained to look at 1 million happy normal slides and find the 5 that are malignant. I find that looking at the things that go wrong or perhaps could be done differently is the best way to figure out how to inform what to do in the future. First thing, I'll just mention that I'm speaking on behalf of 2 laboratories at the Brigham that have collaborated on this. I direct the molecular diagnostics lab. My colleague Manfred Briegel directs the microbiology lab, and we worked on this project and continue to work on this project together. So the first thing I will say is that we have used 3 different tests in less than 2 weeks, starting from design, validation, and deployment, and we're now working on designing and validating our 4th test. And we've developed over 40 tests in the 20 years I've been here, and typically it's a process that takes 9 months, and we're now doing that in about 3 days, which is at a certain level kind of insane, but it's the times that we're in. Our first approach was an RT-PCR, which followed the FDA emergency use authorization test that was designed by the CDC. And without getting into too much discussion of it, the FDA initially required a very specific set of reagents, lots of equipment. We had almost all of that except for the RNA purification piece. The RNA purification piece that got approved became unavailable the day after we agreed to buy it. They then approved a second one 2 days later, and the day after we agreed to buy that one, it also immediately sold out. And so we were not able to get the materials for this. I ended up calling the Undersecretary for Health and Human Services and the head of in vitro diagnostics at the FDA, explained to them what we had, and got their verbal okay to proceed with the system that we had, which then became back-ordered in short order. And so the first point I would stress for all of these is that maintaining assay supplies was a constant and persistent problem in this space, and things that were in tremendous supply around the country would be gone within a day or 2. It was like trying to find toilet paper in the supermarket. So then the second and third tests that we deployed, one last week, another one yesterday. are the Hologic Panther assay and Cepheid Gene Expert assays. These are automated big box assays that are commercially manufactured and supplied. Much easier workflow, random access, so sample can go on at any time, much higher capacity, and they work faster than the original technique that we did, which was manual. The supplies for both of these are limited. One of them has already had a problem with a manufactured lot, and they're back ordered, and another one is being rationed. And so again, for each of these, supplies are limited, and we're frequently finding ourselves in the lab having to pivot and maybe even maintain more than one method at a time, which is not the way we're used to doing things. In terms of performance issues, what we had with the first test, when you added up the time it took to do the test from the SOPs and from our validation runs, it was about 4.5 hours. So we figured, well, conservatively, we'll say it's going to take 6 to 10 hours to do the test. The actual turnaround time, as you've heard from my colleagues, ended up being closer to 12 to 18 hours, and in some cases, 24 hours. So what was the difference? Finding samples, compiling batches, logging into the system, deconstructing batches from step 1 and rebuilding batches for step 2. It wasn't the test itself that was the hard part. It was the logistics and the operations, which are prime determinants of throughput. And we've looked at some of the new methods being developed, which involve, oh, it's just a little pipetting step here and there. But when you start doing that at scale, it really starts to bog you down. And so one of the things I would urge for diagnostic developers who are looking on new processes, if you're planning on implementing something in the central clinical lab, the whole workflow has to be really, really streamlined. Second issue is accuracy. And I'm interested to hear my colleagues both commenting on the sensitivity, because we had the converse problem. So the assay that we set up, we intentionally made as sensitive as we possibly could. And we wanted to basically never have a false negative result, at least given the samples that we had. And so when you do a test like that, and when you have a problem, and then you start looking at other methods, you find that the results don't always agree. And if your test is more sensitive than others, those other tests are going to come up negative. And then you have this dilemma. Does your ultra-sensitive test picking up a signal that's too low for the other methods, or are you picking up assay noise or a false positive? And it becomes extremely difficult to prove, and we're in the middle of it right now, trying to prove that these low-level positive samples that we saw and only we saw were actually real. And so the thing to think about with an ultra-sensitive test is, unless you can kind of quickly confirm in the case where all the other tests that are less sensitive or potentially less sensitive come back negative, that you've got truth, you're gonna have a little bit of a problem. Overall, for what it's worth, we tested a little over 500 samples. And we had 460 true negatives and 15 in this ambiguous category, and then 38 positives. And that's a specificity of 97%. If you assume every one of those ultra lows is in fact an error. And if you say half of them are, that's a specificity of 98%. And so if you went into this saying, I'm going to give you a test with near 100% sensitivity and 97 plus specificity, people would have said, that's great. But the prevalence is so high that your predictive value ends up being kind of marginal on the positives, even with a 97+% specificity. And so what I would suggest, again, for assay developers, if you're going to go ultra-sensitive, you have to also be ultra-specific at the same time, and should be targeting at least 99% for both of those. 97% is not going to cut it with a disease as frequent as this. And so in conclusion, I would say what's needed, we need first and foremost supply chain stability. Can't be running out of supplies every 3 days. Over 99% sensitivity and specificity. The turnaround time's got to be fast, 3 hours at most, and ideally less than an hour, as you've heard our clinical colleagues say. And then, importantly, it's got to scale if it's going to be in the central lab. Reduce as many manual steps as you can, and try and remove interpretation manually if you can. And this becomes limitation for a lot of these one-at-a-time assays. You know, there's a 5-minute Abbott assay, that's great, but you can't do 1,000 of those in a room, one at a time. And so got to think about scaling up. And then I'll turn it over to John.
Thank you, Neil. I think Neil covered a lot of ground, so I don't have to rehash everything. At MGH, the microlab under the leadership of Eric Rosenberg, together with Joe Lenners from the CID molecular division here, have run 3 tests, RT-PCR, the same original test that Neil launched across town. They then moved to a Cobas 6800, which has a throughput of about 400 cases a day at max, maybe a little bit more. And then the Cephia, the same one that Neil was talking about, limited currently by supply. So throughput, manpower, infrastructure, we're good to go. It's really limited by supply chain right now, but for the most part, we're handling the volumes that we currently have. And if I can speak for Eric, we could handle more cases. So I think it's probably time to revisit who we're testing. That's mostly going well. We felt the call for faster, easier tests that could be done at point of care. And so we've been evaluating a number of technologies for the past 3 weeks. I'll split them into the diagnostic category and the serology category. Serology can be used diagnostically. For diagnostics, we've looked for rapid point of care tests. We had a number of tests and still do under evaluation. There's a New England Biolabs assay that's an isothermal lamp assay, can be done in a few minutes. Abbott has released the end of last week their own rapid test. We're also looking at several antigen-based detection assays using lateral flow assays. All of these were exciting because they could be small, portable, and done quickly. But it comes back to some of the issues that Neil was talking about. The sensitivity of those assays are not as good as PCR. And I think I'll look for Neil to nod his head. I don't think there's going to be any test as sensitive as the PCR test that we have now. There are some researchers on the call that might say they're more sensitive, but it's a really good assay. It's really sensitive. And if we move to anything else, even if it's easy and even if it's fast, we risk not being as sensitive and missing some patients. And the question for the clinicians on the call, are we willing to miss some patients? And if you need to know someone is negative and be really confident that they're negative, many of those tests are not the tests you want. Those rapid tests will be good if you could use the information to say, that person who I thought was positive, we now know is positive when we know in 5 minutes. So if you can do something meaningful with those rapid identification of positives, then we have tests for you. But to date, I've been told by most of our clinicians, that's not what we actually need in the emergency room right now. So I'll leave that out there if any of the clinicians are interested in a rapid positive test that may not be as sensitive. Let's talk. From the serology standpoint, we've had a working group together for probably 2 to 3 weeks now, looking at a number of antibody tests, including ELISAs and the more point of care lateral flow assays. The group's evaluated approximately 6 or 7 of these different types of assays, looking for sensitivity and specificity. I think we've made very good progress. We're nearing the end of validation for our lateral flow assay for IgG and IgM. That should be ready this week and rolled out, we're hoping, in the form of a pilot study of about 200 patients. So that's what we're aiming for this week. Antibodies can be used for diagnosis. As I think someone put in the chat room. You can add it to test to increase your sensitivity of detection in the acute phase. But to be honest, we find that only about 30 to 40% of patients under 7 days from onset of symptoms are positive for IgG or IgM. So it's going to have limited use very soon after the onset of symptoms, probably closer to 70, 80, 90% in the 2 to 3 week time frame will be IgG and IgM positive. So we see a real use, as was discussed before, about finding patients who, or not patients, maybe employees who've been exposed but are now immune and can be redeployed. So actively working on protocols to do that. We think we have the assays to do that. We have pretty strong firepower from the Raygon scientifically to begin to look more carefully at individual antibody subtypes and follow those along and correlate them. But we're excited that a point of care test could be deployed and used widely within the hospital. So I'll leave it at that.
Great. Thank you very much to all the clinical folks. I think they really set the stage well. So we're running a little bit short on time, so I'm going to go really through this fairly quickly. Really, the first part of this, well, let me just set this up. So we heard from the clinicians and from the folks in the lab, and really the focus is on assisting the clinicians, the lab directors, lab personnel, the frontline healthcare workers, and also, of course, the patients. And so this slide, I think, describes the what, which is not going to be the focus of our working groups. I just want to articulate a little bit about what we're thinking here is, and we've heard a little bit about this. So the goals are with the molecular tests, as we've heard, can we make them faster and higher throughput? The antibody tests, can we detect whether asymptomatic individuals have been exposed? As we heard, there's a real need for healthcare workers to know whether they've contracted the virus and are just asymptomatic. Also to know if it's safe for the general population to return to work and return to society. And as we heard Rochelle speak earlier, the idea that we could even use this to determine antibody titers so that we could use convalescent serum as a therapeutic before vaccines are available. The third category are cytokines, to measure cytokine storm. Can we predict when patients are taking a turn for the worse? This could potentially be useful for clinical trials also to ascertain therapeutic efficacy. And then there's other approaches. We've heard that patients who contract the infection early lose their sense of smell. So can these sort of correlates of infection be used as diagnostic parameters, and are there other observables that could be used? And then finally, we've heard a real need for testing and retesting, and thinking about going forward where there may be flare-ups in the population. How can we scale this to the population level so we can identify when someone should remain at home, and also just to be able to get the throughput to the level of literally hundreds of millions of tests that we could deploy. So that's the what. What we've done is really set up the working groups according to the clinical applications and the needs that you heard earlier. The specific assay types that were covered on the previous slide should be discussed within each of these working groups and maybe implemented in multiple working groups, but they would presumably be applied in a very different way in the home than in a clinical setting. So, as we heard Dr. Lindemann speak, trying to do lateral flow tests at scale in a laboratory is not going to be, something that would be useful, but in a consumer or home setting, it would certainly be useful. So the goal here of the center, I just want to focus everybody, is to make an impact in the requisite timeframes for these various working groups to actually implement these technologies. This is not a research center, although that may be a component. It's an action center, as we heard from Gary earlier, with how quickly the working groups responded and actually delivered solutions to the hospitals and to the floors. So the first group will deal with some of the issues we heard, the logistics, critical materials, and capacity building, trying to understand what the clinical lab needs are and then to meet those and help the laboratories. The second category is point of service or urgent care. This we think is going to be the next phase of testing, so people can get tested without having these tests be collected as nasopharyngeal swabs and then send them out to the big testing labs like LabCorp and Quest. The third category is the direct-to-consumer. We talked about home testing, but whenever it's available, this would be incredibly useful so people can self-test and stay home if they have symptoms. The fourth working group will be focused on what we're calling a diagnostics accelerator. And this particular accelerator, John just described a little bit about what he's doing with the serological test, with the IgG and IgM lateral flow tests. It's what the conception was, so this was conceived as a collaboration between the Brigham and also the Wyss Institute as a joint program to develop and test new diagnostic technologies. And we actually have lab space located in a CLIA lab space at the Brigham. But now we're going to really repurpose this as a test bed to evaluate new tests. So as John was talking about, if we could get our hands on some of these different kinds of tests that are coming out sort of on a daily basis, both commercially and also innovative new technologies, this working group will be tasked with identifying the most promising ones and then bring them into the accelerator to evaluate and validate those tests. And so it will be similar to the devices working groups in the sense that we had 50 companies, 50 groups that wanted to make face shields and face masks, and those working groups really honed it down to a couple of really promising ones that had the characteristics of being able to scale in the appropriate time frame and really meet the needs and then be validated on a fast turnaround. And then, of course, the fifth working group would be validation, which would set the specifications, the performance criteria, and assess the technologies before they are adopted and scaled. And so we'll now open it up to questions. And we have a few that were submitted in advance, but I guess if you're a participant, you can raise your hand, and I think there's somebody that will unmute you in the background and let you speak. So I'll turn it over to the folks who are in the background. If anybody wants to speak, raise your hand and they'll unmute you. If not, I can just go to some of the previously submitted questions.
David, I have a question from Anna Krachevsky on the chat. And the question is there a plan for MGB to collaborate with big pharma biotech to enhance the supply chain and equipment availability? I think that's a good question.
Yeah, that's a great question. Absolutely. This is not an academic center, as Gary, you'll attest. There's a lot of participation from the private sector. We fully intend to pull in anybody and everybody that's able to assist with the process, and would welcome the participation of pharma and the diagnostics companies. I have another question. What's being done today in terms of testing? What's envisioned the need to be tomorrow, a month from now, and 6 months from now? I think we really have addressed that question in terms of how we've formulated the working groups. And I think we've heard from some of the presenters today that the immediate need is really scaling the clinical lab. Sort of the next phase of it, sort of in the several months time frame, is really getting things into the urgent care and sort of minute clinic kind of test centers, and then perhaps in the fall or late in the fall, getting scaled home testing implemented would be fantastic. So, other questions?
Yes, I have a question.
Yeah, great.
I was just wondering, what's the role of CT lung imaging in the context of the diagnostics that we're talking about here? And then, will there be a working group that'll focus around that type of diagnostic?
Yeah, that's a really great question. I think that's I would say sort of lumped into. With respect to technologies, there's the sense of smell, there's CT scans, all the other data that can be collected that can either, serve as primary information or support the clinical information. As Gary indicated earlier, data is going to be a key feature of how we integrate some of the information, some of the data that actually are collected as a consequence of this testing. And so, Alexander, I think that's a great question, and we're going to have to figure out which of the working groups, it appropriately fits. But, I would throw that into the category of that's a technology that could be used, sort of in a variety of these different kind of applications.
David, can I speak quickly to that?
Sure.
So we've been looking at this and wondering, could we use a conditionally independent test from the one in the lab to try and help our screening of our negative tests? Turns out there are people whose CT changes predate their test positivity and some whose post-date their test positivity. It's obviously logistically challenging with people who are on all the PPE. And then, of course, the people who come into the hospital who are sick often have underlying lung disease to begin with. So in our scan of our first 30 or so, it hasn't really been that helpful in addition to the test to be able to rule out the disease.
Great, thank you. I think we have time for one more question, two more questions. Okay, seeing none, let me, well, we will monitor the chat, and if there's some pressing questions that we haven't answered.
Hey, David,
yeah.
I actually have an interesting question.
Sure.
What is the role of CT lung imaging in the context of, oh, you just did that? Okay, good.
Yep, we just did that. Sorry. Okay, I think now we have to talk about the next step. So at 11 o'clock, the website went live on the diagnostics piece, and I'll show you what the screenshot looks like in a minute. What you should do is to go to the website, fill out the questionnaire to join one of the working groups. So the 5 working groups that we had on the previous slides are part of the questionnaire. And then our goal is to have formulate the working groups by Friday, and then have Zoom calls on Friday with all the working groups, all 6 working groups. There'll be a Slack channel for each of the working groups. The recording of this town hall, for those of you who missed the earlier parts of it, will be posted on the website. And then the next town hall will probably be a therapeutics town hall that will be coming soon. So this is the screenshot of the center's website. You see that it's now populated with devices, and just this morning we loaded up diagnostics. So click on that. That will take you to a questionnaire. If you've already filled out one on devices and you're interested in participating in working group on diagnostics, by all means do so. Click on that, fill out the questionnaire, and then we will compile the names and send out a information about when the working group workshops are going to be held this Friday. Last thing is, one of the things that I found to be remarkable over the last 3-4 weeks since this whole thing sort of blew up is just the tremendous number of people who are interested in contributing and helping to this effort in a very selfless manner. People just offering to do things. They're not doing their research, but they want to get involved in something. And so thanks to all of you for participating. We had well over 600 participants in this town hall, so I'm glad we expanded it to 1,000. The devices one was limited to 500. So glad everybody could get connected today, and hope to have you all involved in a working group. Gary, did you want to say anything in closing?
Yeah, in closing, I wanted to first of all say thanks to everybody and the speakers. It was an outstanding discussion, and the quality of the people in this community is bar none. And so if anybody's going to get to it and solve this problem, I think it's going to be us. So let's get to work to really help our patients and our healthcare givers on the front lines. Thanks a lot.